Welcome to All in All.
Hey there.
So, this deep dive is really tailored for you. Whether you're already a dialysis RN, maybe a dialysis tech, or perhaps you're thinking about getting into this field.
Yeah, maybe preparing for a role in a clinic.
Exactly.
And our mission today really is to sift through a bunch of material, articles, guidelines, practical stuff about nephrology nursing, and pull out the key insights. We'll start with a bit of an overview, but then really drill down into some of the clinical details you absolutely need to know.
Think of it as like a focused look at the dialysis RN job, what you do, who you work with, the hands-on skills, and crucially, how you support your patients.
Okay, sounds good. So where should we start? Maybe with the team. Where does the RN fit in?
Yeah, let's do that because it's definitely a team effort. You're not working in isolation.
Not at all. It's very interdisciplinary. So you have the nephrologist, right? The kidney specialist.
Right. They're kind of the captain of the ship, setting the treatment plan, the prescription.
And if transplant's on the table, you've got the transplant surgeon involved too. They'll assess if someone's a good candidate.
Sure. But day to day, the sources really highlight you, the RN, as being right in the thick of it.
Absolutely. You might be supervising other staff, you're giving meds, handling all that critical charting.
And often you're the main contact, especially for those patients doing dialysis at home.
Right. And working shoulder to shoulder with you is the patient care technician, the PCT.
Mm-hmm. They're essential. Monitoring the treatment, doing the cannulation, putting the needles in, helping with the machine.
Yeah. The nurse and tech together are really delivering that hands-on care.
But it's not just the medical side. There's a whole support system, like the social worker.
Oh, totally vital. They handle the psychosocial stuff, help patients find resources, deal with finances, connect with community support.
Yeah, and even the big things like advanced care planning or figuring out transportation to the clinic.
And then there's the dietitian. Can't forget them. Diet is so critical in kidney disease.
Absolutely. They assess what the patient needs nutritionally, provide tons of education, help with meal planning.
Making sense of all those dietary restrictions.
Exactly. What stood out to me, though, is how the sources emphasize that even with all these experts, the patient is really seen as the most important person on the team.
That's a great point. And your role as the nurse is often to be that bridge, connecting all these pieces for the patient, making sure everyone's on the same page.
And underpinning all this is the nursing process, right? That's the foundation.
Yeah, the classic steps. Assessment, diagnosis, figuring out outcomes, planning, implementing the plan, and then evaluating how it went.
The sources specifically call out Standard 1, assessment, gathering all that data, and Standard 4, planning, creating that individual care plan.
Right. That's the framework for everything you do.
Okay, so building on that framework, let's get into a really core skill, vascular access assessment. This is bread and butter for a dialysis RN.
Oh, absolutely fundamental. You can't do safe hemodialysis without good access assessment.
So we're mainly talking AV fistulas, AVFs, AV grafts, AVGs, and then the tunneled central lines, the CVCs.
Exactly. And for fistulas and grafts, that physical exam is key. It's the classic look, feel, and listen.
Like playing detective with the blood flow.
Kind of, yeah. So when you look, you're checking out the whole configuration, how long it is, looking for any warning signs.
Like aneurysms.
Or pseudoaneurysm.
Right. Or maybe extra veins popping up, those collateral veins. You're looking for signs the hand isn't getting enough blood, like, or the finger's blue or pale. Ischemia signs.
And infection, of course. Redness, swelling, any drainage.
Definitely. And a key tip the sources mention is always compare the access arm to the other arm.
Good point.
Yeah, and don't forget to look higher up too. Face, neck, chest. Swelling there could mean a blockage further up the line.
Okay, so that's look, then feel, palpation.
Right. You're feeling for the thrill, that vibration. Normally, it's continuous, like a cat purring almost. If it feels unusually strong, like really bounding, that could mean there's a narrowing, a stenosis downstream. Interesting. And what about that pulse augmentation test?
Ah, yes. That's a neat trick. You gently press on the vein just past the connection point. The pulse should get stronger because you're temporarily blocking outflow.
Okay.
It doesn't get stronger. The sources suggest that could be an early sign of inflow-stenosis, a problem before the access, maybe before you hear anything different.
Wow, okay. That's a subtle but important finding.
It can be. And they also mention a sequential occlusion test, which helps you map out those collateral veins if they're present. You get good at that with practice.
And finally, listen. Auscultation.
Yep, grab your stethoscope. You're listening for the brute, that whooshing sound.
Also continuous, normally?
Should be. Nice low-pitched whoosh if it sounds really high-pitched or choppy, like staccato. That's another sign pointing towards stenosis.
Okay, so these signs help you identify potential problems early, but what's the really critical finding?
The absolute red flag is if you can't feel a thrill or hear a bruit. Silence is bad news here. It usually means the access has clotted off. Thrombosis, that's an emergency. Needs urgent referral right away for possible clot busting or surgery.
Got it. Urgent. And they mentioned something about recurrent clotting.
Yeah, if a patient keeps clotting off their access, besides looking at the access itself, it might be worth considering a cardiac workup. Sometimes poor heart function can contribute.
Okay, that makes sense. Now, what about catheters, CVCs? The assessment focus shifts a bit there, right?
It does. With catheters, the big concern is infection and making sure it stays put and works correctly.
So care involves keeping that exit site meticulously clean and dry.
Absolutely. Daily checks for any signs of infection, redness, swelling, pain, fever, any drainage. You teach the patient to look for this too.
And patients need clear instructions like, don't pull on it, keep sharp things away.
Right. And interestingly, sometimes just how the patient is positioned can affect how well the catheter draws blood. That's something you observe.
And never mess with the dressing. Right. Let the nurse handle that.
Definitely not. If it bleeds, firm pressure. Call the clinic or doctor. If it's really bleeding badly, 911.
Okay, now what about that scenario? A cap comes off the catheter and the clamp is open. That sounds terrifying.
It's a high-stakes situation for sure. Potential for massive bleeding or a fatal air embolism.
So what do you do? First step.
Clamp it.
Yeah.
Clamp that catheter line immediately. That's priority one. Stop the bleeding. Stop air getting in.
Okay, clamp first. Then what?
Get the patient lying down on their left side with their head lower than their heart. That position helps trap any potential air in the heart away from the lungs or brain.
Left side, head down. Got it.
Then call for help immediately, the dialysis center, doctor. And if they have chest pain or trouble breathing, it's 911 straight away.
Okay, wow. Critical steps. That actually leads us nicely into other complications during treatment. Infection prevention is obviously huge with catheters.
Huge across the board in dialysis. These patients are so vulnerable.
What do the guidelines, like from the CDC, recommend for catheter site care?
They generally recommend using povidone iodine ointment or specific single antibiotic ointments right after the catheter is put in, and then usually with each dressing change during treatment.
But you need to be careful about compatibility.
Yeah, that's a key point. Always check what the catheter manufacturer says. Some ointments can actually damage certain catheter materials.
Right. And they noted some caution around triple antibiotic ointment, didn't they?
Yeah, its effectiveness for these specific infections isn't as well proven, and there are always concerns about antibiotic resistance with broader spectrum stuff. Best to stick to the evidence-based recommendations like the povidone iodine or recommended single agents.
Makes sense. Okay, besides infection, what are some other common intradialytic complications we need to be ready for? Like air embolism.
Right, you might actually see bubbles in the blood lines. That's a clear sign.
Right.
Or the machine's air detector alarm will go off.
And the immediate action is?
Hit the brakes. Turn off the blood pump right away. Clamp the patient's lines, clamp the machine lines, isolate the circuit. Then you investigate where did the air come from.
Okay, what if the whole circuit line's dialyzer just clots off solid?
If it's fully clotted, you have to stop.
Yeah.
And this is critical. Do not try to rinse back the blood. You risk sending clots to the patient.
Right. No rinse back on a fully clotted circuit.
Nope. Discard the whole thing. Start fresh with a new setup if needed. Check their hemoglobin later and let the MD or NP know so they can review things like the heparin dose or check the access again.
Got it. What about muscle cramps? Super common complaint.
Oh, yeah. Patients will tell you, or you'll see them get restless, maybe see the muscle tighten up, painful.
And management is usually non-drug first.
Usually. Things like reducing the fluid removal rate, the UFR, or the overall goal, gentle massage, stretching. Sometimes heat or cold packs help. Suggesting some light exercise between treatments can also be beneficial for some.
Okay. Another big one, intradialytic hypotension. Blood pressure dropping during treatment.
Yeah, a major challenge. There are various ways to manage it. Adjusting how quickly you remove fluid is key, maybe slowing the rate, or using UF profiling, if the machine allows it, to vary the rate.
Monitoring their blood volume in real time if you have that capability.
Exactly. Things like BVM monitors can help guide fluid removal. Checking hematocrit. And it involves carefully managing their blood pressure meds, maybe holding a dose before dialysis, adjusting timing, always in consultation with the doc.
It's very individualized.
Very. And then needle dislodgement or the whole access disconnecting. Another potential emergency.
What are the signs to watch for there?
Sudden pain, maybe? Or warmth, wetness around the site, swelling. The machine's pressure alarms will likely go off too.
What do you do if, say, one needle comes out but the other is still in?
First, yell for help. Get another pouce in there. Depending on the situation, you might be able to return the blood safely through the remaining needle or just clamp everything off. But if the patient hasn't had heparin yet.
Then clotting is a risk.
Right, so in that case, probably best to just shut off the pump immediately, carefully remove the remaining needle, and apply firm pressure directly to the site. And always remind patients, keep that access arm still and visible during treatment.
Good point. The sources also briefly flagged a couple of others, like immediate reactions to the dialyzer membrane or transfusion reactions.
Yeah, less common, but things to have on your radar. Knowing the signs and initial steps for those is important too, even if we didn't dive deep here.
Okay, so we've covered a lot of the clinical management, the machine side. Let's shift gears a bit. Talk about the RN's role in empowering patients. Education, support, that seems huge.
It's absolutely massive. You're not just a technician, you're an educator, a coach, a supporter.
So guiding them through treatment options is a big piece.
Huge. You need to be able to explain in-center hemodialysis, home hemo, peritoneal dialysis, PD, and transplantation.
And not just explain what they are, but the pros and cons from the patient's viewpoint, right?
Exactly. Like in-center is predictable, staff are there, but it means traveling 3 times a week, rigid schedule. Home hemo. More freedom, flexibility, maybe better outcomes, but needs a trained partner. Space for supplies, more responsibility.
PD is daily, maybe gentler, no needles usually, but involved carrying fluid, risk of peritonitis, body image changes maybe.
In transplant, closest to normal life, but it's major surgery, lifelong meds, risk of rejection, constant follow-up. Your job is to lay it all out clearly, neutrally, so they can think about what fits their life, their values.
And dietary education is ongoing, isn't it?
Constantly. Especially hammering home the phosphorus issue. Limiting high phosphorus foods is one thing, but the timing of phosphate binders is key.
They have to take them with the meal, right? Not before or not after.
Precisely. So the binder is in the gut at the same time as the food, ready to grab onto that phosphorus before the body absorbs it.
And you'll give examples of foods to watch out for: nuts, seeds, dairy, colas, but always working with the dietitian.
Always. They make the specific plan, you reinforce it, help troubleshoot.
Then there's medication education. Patients are often on so many pills.
Yeah, complex regimens. Blood thinners, multiple blood pressure meds, maybe calcium, iron, vitamin D, EPO shots for anemia, those binders.
Yeah.
Sometimes meds for sleep or constipation too.
And there are specific things they need to know related to dialysis timing.
Right, like holding certain BP meds before treatment, taking calcium and iron supplements between meals, and not together.
Oh, right, they interfere with each other.
Exactly. And binders with meals, always. And knowing which laxatives to avoid anything with magnesium or phosphorus is usually a no-go.
But just listing facts isn't enough, is it? The sources talked about how we educate.
Yeah, it's about fostering self-care, helping patients not just know what to do, but feel motivated and confident to do it.
That's where things like motivational interviewing come in.
Exactly. It's a specific way of talking with patients, not at them. Expressing empathy, helping them see maybe a mismatch between what they want for their health and what they're currently doing.
Rolling with resistance gently, not arguing.
Right. And really supporting their belief that they can make changes. Supporting their self-efficacy. It's collaborative.
And nursing coaching is similar, helping them gain knowledge, skills, confidence.
Yeah, empowering them to be active participants, setting their own goals.
And underlying all this is the nurse-patient relationship itself.
Absolutely critical. Building trust, communicating effectively, showing genuine support, the sources, really emphasize how much this can boost a patient's ability and willingness to manage their own care. It's not just fluff. It has real impact.
And we shouldn't forget the social worker again here as a partner.
Definitely.
Yeah.
They're key for those practical supports navigating transport options, which can be a huge barrier. And they often take the lead or work closely with the nurse on those important but sometimes difficult conversations about advanced care planning.
Like healthcare power of attorney, living wills, DNR orders.
Exactly. Helping patients document their wishes.
And travel planning, too. That takes effort when you're on dialysis.
Oh, yeah. Whether it's arranging visits at another dialysis center way in advance or coordinating PD supply deliveries to their destination, you help guide them through that process.
Okay, so lastly, let's just touch on the broader professional picture for a dialysis RN.
Right. It's not just the tasks. It's about professional conduct and growth.
Adhering to those standards of professional performance for nephrology nursing.
Yeah, covering areas like ethics, making sure you keep up with education, using evidence-based practice, communicating effectively, collaborating, leadership.
Resource use, environmental health. It's comprehensive.
It is. And the sources make a useful distinction between these broad standards and specific clinical guidelines.
Like the KDOQI guidelines from the National Kidney Foundation.
Exactly. Guidelines are more specific, evidence-based recommendations for managing particular clinical situations or patient groups. Standards are the overarching professional expectations.
And that statistic about kidney disease prevalence? Quite striking.
Isn't it? An estimated 1 in 9 Americans having some stage of kidney disease. It really highlights that your role extends beyond the clinic walls. You have opportunities to educate patients, their families, the community about risk factors, the importance of getting kidney function checked, especially if there's a family history.
So being a dialysis RN is really about being an educator and advocate too.
Absolutely. It's a multifaceted role.
Well, this has been a really comprehensive deep dive. We've covered a lot, your place in the team, those core clinical skills like access assessment and handling complications.
Yeah, and then shifting to empowering patients through education, communication, support, understanding the professional standards.
It really lays the groundwork, doesn't it, for providing that high-quality, patient-focused care.
It truly does. It's foundational knowledge.
So here's a final thought to chew on. We know dialysis is technically complex. Patients face so many challenges, physical, emotional, logistical. How much more impactful can care become if we, as nurses, consciously focus on building strong relationships and really lean into techniques like motivational interviewing? Can that shift the patient's experience from just being tied to a machine to feeling like a true partner in their own health journey?
That's the key, isn't it? Moving beyond just the procedure to connecting with and supporting the whole person. It could change everything for them.
Thanks for listening to All in All.